So I apologize. This is your first slide on week 6. So anyway, when you have hematological immunologic dysfunction and you're getting these symptoms type things, again, you're going to diagnose it, number one, by just a simple CBC and just that assessment, that fatigue, that always fatigue, especially in young infants. They have fatigue that they can't finish their food. That happens with the cardiac problems, respiratory problems, even hematologic if they get too anemic or if their immunological is defunctioning and causing a lot of infections. So anemia, most common, all of the hematological problems. And all that is your hemoglobin hematocrit are lower than it should be. Well, what is hemoglobin and what does it do for the body? Well, hemoglobin carries iron, food for the cells, and oxygen, so they get what they need to live, right? So if you don't have enough cells, so your hemoglobin is low, not 14 about where it should be. So let's say it's 7, which sickle cell could go to 6 or 5. If you have it low, that means oxygen's not being carried to the body. So your brain's not getting what it needs. You're going to be confused. You're going to be tired, lethargic, no energy because you're not getting iron. You're not getting food to the body. So decreased number of RBCs, hemoglobin's low, decreased oxygen. I'm not going to be able to move and do what I need. Now, in children, it's not that 14 number that you see in adults, that 12, 14 is normal. It's a little lower. We accept a little lower because, especially the younger kids, we know nutritionally, they're just not going to be eaten properly, especially toddlers. And also remember, infants, they don't start making their own cells to about 3 to 6 months, and mommies go away. So again, they have low hemoglobin, low hematocrit, and unless they're symptomatic, we do nothing. So anemia, you get a kid, comes in, doctors, the patient, the family or the kids telling you, I'm just so tired all the time. I don't know what's going on. And you look at them and they look pale. I mean, you can see the pale lips, the pale ears. You can look at their palms of their hands, soles of their feet. Just look pale, right? The next thing I am going to do is I'm going to listen to their heart. Okay. When you have anemia, you don't have a lot of blood cells in there. So when their normal blood volume, normal hemoglobin hematocrit is full up, so it just slides through there, it slides through there, and you don't hear any sort of blood flow. Now, when they're anemic, those cells bounce off of each other. So you're going to hear this murmur going through all of the valves of the heart. You're going to hear it because of the low hemoglobin hematocrit. Now, what does the body do when it doesn't have enough hemoglobin, doesn't have enough oxygen, iron? The body says, let me try to make more cells, right? Well, that's going on, but in the meantime, the heart's saying, well, let me beat a little bit quicker. Let me try to get that oxygen around. Let me try to get that iron to the body. And it beats and it beats and it beats, and cardiac failure if it goes on too long. Makes sense there, doesn't it? You're not going to get oxygen. They're going to be cyanotic, and they're not going to be growing the way they should because they're not getting the nutrition they need, the oxygen they need for proper growth. Now, there's different sort of anemias that we look at. There's decreased red blood cell production. Okay, that is your iron deficient anemia. Okay, that's one of them. And then we have increased red blood cell loss. I mean, that could be just a nosebleed, but there's other things. And then increased red blood cell destruction. That means the blood cells are formed, but they die quickly. So let's start out. This is a thing right out of your book. This is one of those things that I just copied and paste from your book because it really tells me everything. So, decreased red blood cell production. If you look at the symptoms, you're going to see all of this fatigue, headache, tachypnea, tachycardia. You don't have red blood cells, the body's going to beat faster, blood pressure is going to be lower, you're going to get tired quicker. All of that, all of that. It's going to affect the spleen, the lungs, the muscles, the heart, everything. So, it could be any of those symptoms there. Now, nutritional. Iron, number one. We've discovered that already. B12. B12 is interesting. That's that beefy red tongue that you would see. I was reading about that. I've never seen a B12 deficiency. Iron, of course, all the time. The other way decreased red blood cells is a bone marrow failure. So if your bone marrow is not producing cells, you're not going to have them. This you would see with things like aplastic anemia. I'll go into what that is. I think that's the worst of all the anemias, if I would guess. And then ALL, acute lymphocytic leukemia, AML, ALL, any of those leukemias. Of course, bone marrow's failing, white blood cells are not being formed properly. Then you have acute blood loss. One of the things that I have seen with children with these things like ITP, hemophilia, DIC, one of the first things that they come in with is a nosebleed. And that nosebleed is not the first one. Usually they get a nosebleed and okay, they hold it. It happens again. They go to the doctor. They say, oh, he had a cold. Let's paint it with Vaseline. And then it happens again and again. And now it becomes worse and worse. That's when they go to the ER where I worked. And then we were going to, well, of course, we're going to pull the CBC. A lot of bleeding going on here. Let's look at the blood cells. And then platelets are extremely important in bleeding coagulopathy, right? So, one of the things that we see with nosebleeds is something called ITP, idiopathic thrombocytopenia purpura. It's ITP, P for platelets, low platelets following upper respiratory infection. It's usually acute. We usually take it away, but I'm going to go into that a little bit more. Increased red blood cell production. You've all heard of sickle cell. Yes, the cells are shaped weird, but they die quickly. Another one that I call a weird shaped cell, I call them rectangular only because that's the pictures, but you have a sickle and a rectangular, and they both, they burst, they die very quickly. Those are the two you need to know there. And then we know red cell, blood cell destruction can happen if you're on chemotherapy or radiation, severe infection and sepsis. All of those things can cause it too. So now let's go over into some of this stuff now. So how do we take and how do we, manage, anemia? Well, first of all, you've got to diagnose. You've got to say, all right, this kid is pale, they look tired. Let's do the CBC. Okay, hemoglobin is 7. What do we do next? Well, why are they bleeding? The first thing they always do for any bleeding, they're going to do a stool for occult blood. You always rule out GI bleed first, don't you? Let's rule out obvious before we start looking for these big bad things. So now, if that hemoglobin was 6, 7, that kid was so lethargic and really tachypnic and tachycardic, that child would get a blood transfusion. We need to replace the hemoglobin, the iron, that heart rest a little bit, okay? But we still got to find out why that child had that anemia so bad, okay? Another thing we'll do is we'll give some IV fluids. With anemia, they don't have enough blood volume. It's not going quickly enough and the heart's beating quick. So we will give that extra volume with blood or IV fluids. And then they say oxygen therapy. Now, I want you to know it's very controversial. If you don't have cells, how's the oxygen going to get on it? And how's it going to be carried to the body? So, yes, it can help maybe, but it's, if you don't have cells to carry it, there's nothing to get the oxygen to where it needs to go. Very little gets there, but they do say put it on, it should help. But I've had doctors say, oh, if you want to put it on, it don't really matter. I've had doctors tell me that. So caring for this anemia. Well, number one, let's rule out what type of anemia this is. The background might tell you sickle cell, African American, right? Thalassemia, people from the Mediterranean Sea. So these things are giving us clues. And then, of course, the history. And then what did I tell you? Stool for occult blood. We want to make sure it's just not a GI bleed or an ulcer, because kids do get ulcers, okay? Now, anemia, what are we going to do? Well, we're going to do blood tests. We might have to give blood transfusions. We might have to give medicines or IM medicines or PO iron, or we'll have to do something, right? So prepare that kid on their level, right? Very important because it's going to be an ongoing thing because anemia could be nutritional and then we could just change the nutritional habits, but it's still going to have to be monitored. They're going to get stuck with IV sticks, but we can make that painless today, can't we? We can give that numbing creams and make it less frightful, that no pain. So iron deficient anemia. It's because they don't eat enough iron. I mean, how many kids like their broccoli and likes their spinach and likes liver and all that stuff that's high in iron, right? No, not really. I mean, I had a very weird grandson. He loved broccoli. It was one of his favorite things. He'd sit that big pile of broccoli. That's why I put that picture there. That was Christian. Oh, just not butter, anything, just broccoli and broccoli. And that's what he would eat. But not all kids are like that. Very, very, very uncommon for infants to be iron deficient anemic because we give breast milk for the first 6 months or iron fortified formula. At 6 months, we introduced iron fortified cereals, and iron is in the foods that we eat, the green peas and the spinach and all the beans and proteins and all that. That's all there. They're all getting it. So we are taking care of that. We know adolescents, they are at risk for iron deficient anemia. Think about you as an adolescent. You went from that, all of a sudden you growed really tall, you lost some weight, and now you're not eating because you're too fat and you like this guy, you like this girl, and you got to look good, so you don't eat. What does that cause? You're not eating nutritional iron deficient anemia. Very common in the adolescents. The other one it's very common in is toddlers. Think about toddlers, what they eat: chicken nuggets, macaroni and cheese, apple juice, nothing else. Well, where's the iron in that, right? And some toddlers are that picky, will only eat that. So, again, we've got to put some iron in that diet somehow, some way, or we need to give them a supplement. Now, do you remember how to give iron supplements to a child? Liquid iron, it is brown and it stains, okay? So through a straw, let's keep those teeth nice, pearly white, okay? Remember, it has to be on an empty stomach. Iron has to be broken down by an acid in the body so it can become useful. Gastric acid, right? That breaks it down. Empty stomach, let it get to the body. Drink it with orange juice. More acid, let's get it to the body quicker. Never milk, never during or after a meal. And please, can you imagine a parent seeing a black tarry stool coming out of their toddler and you didn't tell them their stool is going to be turning this? I would be flipping out. So please tell the parent that the stool is going to change. The other type of iron we could give is iron dextran. It's deep IMZ track. Again, it stains the skin, it burns. You want to lock and load it inside the tissue so it doesn't ooze out and cause problems. Okay, sickle cell anemia. What you need to know here is if both parents have a trait, not the disease, both parents have a trait, every child has 25% chance of getting sickle cell, the disease, not the trait. Okay? So, sickle cell. What do we know about sickle cell? Sorry, driving you crazy. Sickle cell is these blood vessels, these red blood cells, instead of being round, it could be mobile and bounce off of each other and go through the blood system easily. They become these sickles. And what happens with these sickles, they're irregularly shaped and they can hook. So when you get these bifurcations in the blood vessels, it gets hooked up and it can't go down distally. It stays there and it's stuck, and other blood vessels come and sit on top of it and keep coming because blood keeps coming, the heart keeps beating, and it gets bigger and bigger and bigger, and it hurts and it's painful. It could be in the brain, it could be a stroke, could be in the chest, could look like a pulmonary embolus. Those are your big emergencies, okay? But it could be in an elbow, a knee, a shoulder. I mean, it could be in a foot, an ankle, a wrist, could be anywhere. Now, what do you think that the biggest problem with is? Distally, blood is not getting there, right? So cell death is going to happen. It's going to cause great pain. These children, when they come into the ER, they are pale. They really can't even hold their head up because they hurt so bad, and they're usually tearful. And our job is to get them back. So how did they get that way? Well, something happened where maybe they had a fever or trauma, or they were out there playing sports and didn't hydrate well. Okay, because that's a big thing. Big thing in sickle cell is hydration, hydration, hydration. At all times, hydration. Go up in an airplane, that pressure, hydration. Go out and play sports, hydration. Go on a mountain, hydration. This is how we treat just day to day with the sickle cell. Stress can cause problems with it. And then this is that increased blood viscosity due to dehydration. So what happens with dehydration? Blood vessels get smaller, sickle cells get stuck, and there's more chance for a sickle cell crisis. So I've told you you've got this big, let's say it's in the knee. You've got this big swollen knee and it's painful, and this kid is screaming. He's a 20 out of 10. You know, what is priority treatment? You can do two things. You can treat the symptom, which is pain, or you can treat the cause, which is dehydration and small blood vessels. Treat the cause, but have the pain medicine in the other hand. If you start an IV and give a bolus of fluid, you're dilating those blood vessels, hoping that those blood cells go through the vessels. Okay. Also, put heat on it, vasodilatation, because now you're relieving the pain caused. It's that clogged up blood cells. So now you're starting to hydrate, you're getting to plumping up those blood vessels, plus you're making them bigger by heat, and now the cells start going through, and eventually that pain will decrease. Now, I'm not saying to have start the IV. In my other hand, I have pain medicine and probably an IV antibiotic. I mean, all at once, but priority number one, please give them something to hydrate, open up those veins. Let's treat this, the cause, not the symptoms. Now, the one thing that I've always seen is, as I said, sickle cells die quickly. I have seen, if I have a hemoglobin of 7 with sickle cell disease, I'm actually happy. It's actually quite high. I see them come in at 4 and 5. Can you imagine 4 and 12 hemoglobin hematocrit, 5 and 15? These kids are pale and they're weak and they can barely hold their heads up, okay? We give blood in the ER. That's how severe that is, because usually you would wait. One thing we do with sickle cell children, the young ones, up to about age 5, because they are immunosuppressed, sickle cell children are immunosuppressed, we will give them one antibiotic prophylactically every day to help fight infection so that they don't get fevers, they don't get dehydrated. And we give that up to about age 5. And it's Penvk is the one that I've seen quite universally given. We also will monitor their blood, their retic count. I mean, is that bone marrow functioning it? What do we need to do? You know, it's giving us that idea. Now, prognosis is actually pretty good. There is no cure, okay? This is something that children and adults need to be aware. If they are feeling ill and they have a fever, any patient, this is important, any patient immunosuppressed, running a fever, ALL, fever, anything, fever, this is emergency. They need to call the doctor and they need to start antibiotics. They don't have an immune system. If they have a fever, there's no defense in that body. Let's start those antibiotics. And that, if these children and adults become very compliant with understanding that, they'll live well into the fifth decade of life. You know, but it does take a lot of dedication. So again, seeking intervention early. I got a fever. Let's call the doctor. Let's start antibiotics before I end up in the ER, right? And then, as I said, the two worst type of sickle cell is headache and your chest pain. So signs of stroke, respiratory problems, could be a pulmonary embolus, could be a stroke that's happening with a headache. So you need to evaluate that more, checking pupils and, you know, all your neural signs, et cetera, et cetera. And the other thing with any kid with any disease, we try to treat them as normally as we possibly can. I mean, these kids can go out and play sports and do all that good stuff, but They better have fluids with them. They need hydration, hydration, hydration during the whole time they're out and playing, and an electrolyte solution too. Okay, you heard me talk about a rectangular shaped cell, right? Well, this is thalassemia. Now, there's a couple different types of thalassemia, and I'll mention them in the next slide, but this is Cooley's anemia. And what happens is it's genetic, just like sickle cell. And what happens is the red blood cells, I call them, as you can see, they're rectangular shaped, and they die quickly, but they don't just die, they burst. What's inside a red blood cell? Iron and oxygen. They go into iron toxicity just by their red blood cells. Okay. That's the big thing with thalassemia. They lose oxygen and they lose iron. So these cells, they die quickly. So again, they are always anemic. These are the four types, but again, you don't have to know the types. Just know there's some, they're less severe up to the most severe, but we talk thalassemia, we talk about the one that requires transfusions to live. There's no other way to treat this. Their cells die, we replace them. So we've got a hemoglobin that goes up with a transfusion, and then when our cells die and the hemoglobin goes down and the heart beats faster, and then we get transfusion, we are making that heart work and stop and getting all confused. And the heart is usually what causes the big thing. Now, how do we know somebody has thalassemia? Well, at birth, mommy cells are there. Okay. So, about 6 weeks of age, we're going to see things like cognitive problems, growth failure, because they don't get iron and they don't get oxygen. So the body's not getting the quote nutrition they need, right? So you're going to see that child who's small. You're going to see them cognitively not even trying to lift their head up or coo or nothing. Well, these kids, we're going to do a CBC and we will find those cells and we'll find the hemoglobin hematocrit low. So what is the big issue? We burst oxygen into the blood volume and iron. So now we are iron toxic. But there are drugs. They are called iron chelating drugs. The one that, is in your book is Desferal. It's an oral medicine. You take it, it combines with the iron and excretes it out through the kidneys. There's some times where it is so severe, they might have to put these children on what we call apheresis. It is like dialysis, but it only pulls off what you want, whether you want to take platelets out, iron out, some toxic thing out, it only will pull that out of the blood. It's pretty neat, okay? Nurses actually run it. I never got taught on that one. So, care of management. As I said, your cells are always dying. All the iron, all the oxygen is going in there. So we need to make sure that this patient, this is the Cooley's, this is the major, this is the most of all the thalassemias. They are going to require chelation therapy and transfusions. And that chelation therapy is important, or they'll have seizures and they'll go cognitively, they'll be completely, their brains will be fried because of all that iron that's in there. These children are chronically getting blood transfusions, so again, it's us helping them dealing with coping with this stuff and the family coping with it. And then I think the most important is if they're getting all these blood transfusions, they're going to end up with some sort of transfusion reaction. And they're probably going to end up with these weird antigens that's hard to find blood for. So that's the big thing with thalassemia. As I said, they can live, but many of them say, let's just take the spleen out because it's producing cells that aren't working, putting iron in my body, which is killing me. So let's take that out. But many times, because they are autoimmune, immunosuppressed, they die from sepsis. They say maybe a bone marrow, but they're not even sure. Even with sickle cell, they say bone marrow can be, but it's not always. I've seen both ways go on there. Now, aplastic anemia. We are going to talk about this pancocytopenia, okay? Aplastic anemia is red blood cells white blood cells and platelets are all low. Oh my goodness, huh? So your white blood cells are low. I can't fight infection. My red bloods are cell low, so now I'm anemic. And my platelets are low, so I'm thrombocytopenic and I'm bleeding and I've got bruising and petechiae. This is an overall, probably I think of worst of all the anemias. We treat it very, very similar to leukemia, okay, because there's cells that just aren't doing well. Defects in hemostasis, bleeding problems, clotting problems. So bleeding coagulopathies, we know that there are factors that help, factor 8, factor 9, von Willebrand's, we know platelets, we know other stuff in the blood that does help with the clotting of the blood so that when we get cut, we're not going to keep bleeding and bleed to death, right? Mommy carries a trait. 80% of the cases, X-linked recessive, mommy gives it to them. Now, what we need to do with hemophilia when we determine that's what it is, we got to figure out what's missing, what clotting factor is not there. The most common is factor 8. And then we have factor B, which is factor 9, or Christmas disease. And then one that I've heard of, von Willebrand's disease. Some researcher named von Willebrand found a factor, but it's that one in combination with factor 8. So these children bleed when they're cut. So what do we see? Well, these children would present where they've got all these bleeding, ecchymotic areas, bleeding in the joints. We're seeing those things. When we get a child initially, we're going to want to do all sorts of factors and all of these specialized lab tests. They take sometimes a week to get from a specialized laboratory. So what do we need to know to look at it? Well, prolonged PTT time, normal platelets, and then parathyroid and fibrinogen levels are normal. Those are other parts of bleedings, but platelets are normal. Okay, and you know, in this thing, but your PTT is prolonged, and that's going to give you a clue. So, how do we manage hemophilia? Well, mostly they're done at home, aren't they? This is these parents and children are taught how to give themselves their home therapy. It could be as simple as desmopressin. Sometimes there's just a nasal spray that's a milder one, but let's talk about the one that needs a factor 8 or a factor 9, okay? So, kid is at home, falls down, falls on his knee, and it's bleeding, it's getting swollen, and you know it's bleeding. What do we do? Well, we do what we call rice, not the pea yet. Let's just do the rice. So they need to sit down immediately. They need to constrict the vessels by ice and then compress it, which helps like putting a finger on a bleeder, and then elevate it above the heart so that we can decrease the bleeding. When we are first diagnosed, especially toddlers, that's where the pea comes. Better take the house. Anything sharp, coffee table, sharp corners, you need to pat them. These kids will go around and they're toddlers. They are going to bump into stuff and they're going to cut themselves. So that's the protect on that one there. The reason why we don't want these kids to be always falling and get their knees, their elbows, their fingers, their toes, you know, always with this bleeding inside the joints is because blood is very caustic and it can damage joints, okay? And it'll end up, they're crippled, end up in wheelchairs. So again, it's knowing what to do, how to do it. Prognosis, well, they can live a great life. They just got to, when they bleed, they need to take their medication. You know, and I'll tell you a little story now. An eight or 9-year-old little boy came into the ER with his father, and he was a hemophiliac. He brought his little factor 8 in with him. And then the reason was is the kid fell down on his knee and it was swollen and it was bleeding and you could see it and it hurt. And he tried to call hematology because I guess he had just had a factor and wanted to know if he should give him the factor and didn't want to just give it. So he came to the ER to ask our physicians. And the physician said, yeah. Well, I was a nurse on that child, but I had a brand new nurse orientee with me, showing her around things. And the father said to me, can I give it to him? We know how to do this. We can do it together. I said, would you mind if me and my orientee watched? He says, no. I'm telling you, this gentleman's technique was textbook, almost as good as mine. And I'm pretty OCD. He took, washed his hands, put out his stuff. You have to take the powder and a liquid. You have to pull it up. You have to put it in, pull it out, and put it in a butterfly. The kid picked out the vein he wanted to use, helped him with the tourniquet, and held the butterfly there where the father pushed in the medicine. It was the most beautiful thing to watch. So it can happen and it can be working beautifully. That kid's going to do good. Okay, another one that I've seen is something called idiopathic thrombocythemia purpura or immune idiopathic thrombocythemia purpura, which is ITP, which means P, not enough platelets. What I said is there's usually some sort of upper respiratory that has happened. And then all of a sudden, this child's going to come in with purpura, these little purple little rashy things, and maybe ecchymotic areas type on them there because they're bleeding inside. So that's sort of the purplish looking thing. The sort of stories I hear from parents is they bring him in, and I've seen a couple of them. They come in saying this kid doesn't go out, he doesn't play, he's on the iPad or he's on a gaming thing all the time. I don't know why he's bruising. Has he been sick lately, Mom? Oh, he had an upper rest. He had a cold, a couple of weeks ago. Well, what am I going to do? Number one, how am I going to diagnose ITP for platelets? CBC. I'm going to do a CBC and check that platelet count. Platelet counts are less than 20,000. Usually 10,000 is what I see. And platelets should be above 100,000. 100,000 is the low. So what's happening? This kid is doing that little platelets underneath. So how do we treat this? Well, it's not an infection or anything like this. This is a bleeding issue. We give, and it's supportive, IVIG, boost that immune system so they can fight, so the body doesn't attack its platelets, and anti-D. And those are the things we give. Now, as a nurse, how are you going to care for that child? Well, you've got a kid who's bleeding. He's got low platelets. So you're going to put them on bleeding precautions, which means no venipunctures if you absolutely possibly can. You'll even draw your labs through the IVs, give meds through the IVs. We don't want any pinches, any injections, because it will bleed, and it will bleed, right? Because that's part of it. Also, look at the gums, look at the urine, look at stool. Are they bleeding anywhere? Are they ecchymotic areas anywhere? We're going to look for that. And usually, because we are giving active treatment, we'll be doing blood counts every single morning, which is your platelets. I want to see, is it helping? Is it coming up? And this is sometimes, yes, corticosteroids are given. And again, anti-inflammatory, it helps the body relax and stop fighting itself. Now, epistaxis, nosebleed, is what usually brings these kids in. These kids come in, they've had these nosebleeds, it's been going on, and we don't know why. It could be several things. Now, I've already mentioned an ITP, but it could be leukemia. Okay, it could be something else. It could be von Willebrand's. That's usually diagnosed a little bit later. So you've got a kid and they're bleeding. What do kids do when they're bleeding, especially your young school age kids or your young preschoolers? They flip out. Oh my God, I'm going to die. I'm bleeding to death, right? They don't, and they want to run around. And, No, first of all, you want their heart rate to come down, their blood pressure to come down, calm them down, put them on mommy's lap, do whatever. I always had, as I said, stickers in my pocket. You wouldn't believe what a sticker does. A kid's crying, screaming, here's Spider-Man, here's Batman. Oh my God, they're happy. So again, get them calm. thumb, forefinger, 10 minutes, lean them forward. Because you put them back, they're going to be swallowing blood. And you don't want that because then they'll vomit clots of blood. So lean them forward. If afterwards, after 10 minutes, if it's still bleeding, they need to go get medical treatment. They can either cauterize or they can put these actually what they call nasal tampons. It sort of puts pressure in there. All different things can be done to stop that bleeding. And of course, why are they bleeding? Yes, we got to stop the bleeding, but why? Is it ITP? Is it leukemia? Let's find out. How? Simple CBC. So HIV/AIDS, why are we mentioning this? These are kids, right? Well, babies are born and babies are born to mothers with HIV. We know adolescents, they are doing risky behavior. So we've got to be aware of that and, help our adolescents with it. Now, what we do with HIV and AIDS in children. And, I was working in newborn ICU in the early 80s when HIV became this, oh my goodness, everybody had to wear gloves and it had to be latex gloves. And, it was this thing. Also, I remember adult patients in rooms where we dressed head to toe with caps and gowns and goggles and booties, and because they didn't know how to treat it. Now, this is the interesting part. You have a mother, HIV/AIDS. They get on this HAART or highly active antiretroviral therapy, usually somewhere about 22 weeks, and then they continue it at birth. Why do we give this highly active antiretroviral therapy? Well, it's there to make the infant's immune system as strong as it can be, so it can improve it. So what we want to do with HIV and AIDS is to give these drugs, right? But our goal is to improve it, but to put them, that they can get rid of this disease. Now, I'm like, you get rid of HIV? I thought you had HIV, it was there for life, right? Everybody thinks that. Well, what I started to see in the 90s is where we're giving these antiretrovirals, still very new in the HIV thing, right? Well, what we see is these infants immediately at birth, we start putting them on these drugs, these antiviral drugs. And I've actually seen this is a triplet. One had HIV, one had AIDS, and one had nothing. I've seen infants be HIV positive at birth and at 1 year, zero convert, no HIV. So it is worth going through all of the therapy, okay? Now, what are some things we see with HIV? Most common of all of the opportunistic problems is that pneumocystic carditis, pneumonia. There are going to, collapse in their lungs. Some people want to put yeast and whatnot, but no, it is PCP pneumonia. So that is that. So managing hematological, immunological disorders, right? So we're going to be giving all sorts of blood products. Well, we're not going to give platelets to that ITP patient, believe it or not. You think, oh, just give them platelets. It works, right? It doesn't. That one we have to give that, IVIG and your vitamin D, and that's going to build the immune system up and let those platelets work for themselves. But there's sepsis where we're going to be given packed red blood cells, platelets, FFP, plasma. We're going to get everything, is going to be given. The only thing I'll tell you about blood transfusion is always follow what your hospital has as guidelines. You have somebody to check the blood, vital signs before, 15 minutes later, another set of vital signs, and every hour for up to 4 hours of the administration of that blood. I mean, it's usually what hospitals are, but again, check it, and then you're always going to be safe. As I said, what apheresis is, it just removes a component. And a lot of times with these sort of problems with blood, they're going to be doing a bone marrow. Now, I don't know if you've ever seen a bone marrow procedure being done, but It's either in the sternum or in the hip bone. And they take this long thing with like a T and they hold it and go into the bone. And it sounds like that. It's like you can hear it. But they numb the outside, they deep penetrate it with lidocaine, but it still hurts. Again, I've said it before. I told you you're going to hear it about 28 times. If it's going to hurt, tell the kid it's going to be hurt. Be honest, and you'll do the best you can to make it as little as possible. So, both parents have a sickle cell trait. What's the chance that each of their children will have sickle cell anemia?
25%.
25%. All right, let's go to our first cahoots. Any questions?
Ms. Bogart, my internet is acting up. I'm going to log off and log back on. I'm coming right back.
Let's give her a chance to come back in. She likes to play. Yep. Okay, we got a yep, so we'll get going. Here we go. I think it's 21, something like that, questions. 32. What is priority treatment for a newborn of an HIV positive mother? So you got a child with HIV, mom's HIV. So mom's got a virus. It's pretty serious. So our big thing is to just improve that immune system. So if I give antibiotics to a patient with a virus, it's not going to do anything. Be careful. This is one of the biggest things I see with students. If it's a virus, remember, antibiotics will never be the answer. And that's usually that one to catch you up. They're going to put it in there. HIV, what we want to do is give that kid the best chance we can by improving their immune system to get rid of the disease. What kind of hematocrit would someone with sickle cell have and why? Remember the chart about blood and sickle cell? Which one was it? So you're going to have a lower hemoglobin, and not because the cell's not being produced, but they die quickly. Just like thalassemia, they don't die, they burst, which is dying that they put the stuff into the iron and lose the oxygen. So sickle cell is the shape cells, and thalassemia, they're similar in many different ways with hemoglobin. They're both low. What is the nurse's priority with a child with sickle cell disease who's currently experiencing a crisis? Priority. What do you do first? And I'll ask you the question. You want to treat a symptom or you want to treat a cause? That's the answer. And that's the way I want you to think. And as I said, I'm going to do all of those, absolutely. But my priority is let's treat the cause. Let's dilate those blood vessels so that we can try to get those cells through. I'm going to put a hot pack where it is to dilate it, to get it through. I'm going to be giving morphine as that bolus is going. And it's always, they come in, they're always going to get antibiotics, just to be sure. Usually they're running little fevers too. So we're going to do all of them, but priority. Remember that one. What is the reason children with iron deficient anemia are tired, easily tired? We don't have enough red blood cells. Again, why do they tire? Because red blood cells carry oxygen and iron, gives them the strength and it gives them what they need to get up and go, go, go. A multi. The nurse is teaching about newly prescribed iron supplementation. What should be included? You're always going to get a question on this. Always. And I know I taught pharmacology. We had those questions there too, but it's coming back at you. Take on an empty stomach because we need that acid in the stomach to work. But oh, let's take some orange juice to make that acid even more acidy. Let's drink it through a straw so that we don't stain our teeth. Tell them, please, that the stools are going to turn black or they're going to flip out. And we will never take it ever, 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 ever with milk because that coats the stomach and it won't have acid and any iron won't work. And we take it well before meals, not after. Good job, guys. Aplastic anemia includes a depression of which blood cells? Remember, it's everything. This is a horrible disease. Red blood cells, white blood cells, platelets. So they're anemic, they've got neutropenia infections, and they're bleeding, low platelets, all of the above. Most common type of anemia is iron deficient anemia. Yes, it is. And you know, there's a cure for it. You just need iron. What causes pernicious anemia? I didn't mention it, but mention it here. So pernicious anemia is a B12 deficiency. That's what's in the stomach, okay? And we don't have it. A lot of times B12 deficiencies are with children and adults that have like ulcers and they don't have enough space, I guess, to produce enough B12. What is a symptom of B12 deficiency? And it is that sore red, they even say beefy red sore tongue. I've never seen one, to tell you the truth. Which symptom is the single most common symptom of anemia? Anemia, not enough red blood cells. What's going to happen? I'm tired, period. I don't have oxygen, I don't have iron. I'm tired. When teaching parents about beta thalassemia, the nurse informs that the child is at risk for what? So, the biggest thing about thalassemia is the blood vessels are exploding. So oxygen's going away, so you're hypoxic. Also, iron is being thrown into the blood system. So now you've iron overload. How do we treat it? Oxygen therapy, you give a transfusion, and chelation therapy, get rid of that iron, whether it is a apheresis or medicine. What lab values will you see with hemophilia? What's the bleeding problem here? Right? Hemophilia is bleeding. So what lab values are bleeding? And the PTT is prolonged, and the PTM platelets are normal. Low platelets, ITP, okay? And it could be leukemia too, or aplastic anemia. What is immune thrombocytopenia purpura? ITP. Usually following an upper respiratory infection. Usually it's acute, but occasionally it can become a chronic problem. But usually it's acute. It takes up to after a year of treatment, then we call it chronic. But it is a decrease in the number of platelets. And the problem with it is not enough platelets, then you're going to have that bleeding, that purpura, that's something going on that you will see. Thrombocytopenia can cause the following symptoms. I don't have enough platelets. That's thrombocytopenia. You need to know the terms. So, petechial hemorrhage, ecchymosis, and epistaxis. That's all the ones that we always see there. A multi. A child with hemophilia has fallen and the knee is swollen and painful. Treatment would include what? So the first thing we do if we are suspecting a child has bleeding, let's say into a knee, right? We want to, number one, sit them down. So it is that rice thing. So we are going to rest, ice. We are going to put an ACE on them, and we're going to elevate that leg. So no exercising. We don't want hot packs because that increases swelling. We want the cold packs. What is a priority nursing action for suspected blood transfusion reaction? What do you do if all of a sudden patient develops a rash or spikes a fever? Usually fever is what I've seen the most with blood transfusion reaction. Number one, you just stop it. What you do is number one, you stop it and you take the bag and return it all and send it down to the blood bank. Yes, but first, turn it off. A child is admitted with neutropenia. Which nursing action takes priority? You have to know what neutropenia means. Excuse me. So, neutropenic means the white blood cells are low. What does low white blood cells mean? I'm at risk for getting infections. That means I'm immunosuppressed at this point. My white cells are low. I can't fight infection. The number one priority is hand washing. Always hand washing. It's not contact, it's hand washing is number one. If anything else is needed beyond it, it starts with hand washing. When distraction is used with pain, it helps what? I mean, again, remember, this is hematology, and, they're going to be stuck with IVs and maybe even getting bone marrows and they hurt, right? So again, distraction is great. As I said, I've always had stickers. I still have some of my draw from the kids that I've had, some, I think some Cinderella things and princesses and whatnot. But it helps so much because they forget. They forget other stuff is going on, like, and they like, something else to focus on. Kids don't want to focus on pain. They don't. What assessment question needs to be asked to a child with possible rheumatic fever? I'm always going to go backwards and ask you questions from last week. So, rheumatic fever is all about that sore throat. It is a strep infection that was not treated completely or not at all. And it will hit. The problem with rheumatic fever is there's all these symptoms, including that weird chorea movements that they get in and the rashes and polyarthritis. But the thing about it is everything can be reversed with long-term antibiotics. But once that heart valve is damaged, it is damaged. It's going to have to be medically or surgically treated. Signs and symptoms of asthma. Remember expiratory wheezing. Remember croup epiglottitis is all up here. Air can't go in. That's inspiratory. But in asthma, the air goes down, gets in, and it gets stuck because everything's swollen and now it can't get out and trying to get it out of them. That's what they sound like. And you can hear audible wheezing. A multi. What symptoms should be reported to the healthcare provider for a child with sickle cell disease? I mean, they know certain things go on, right? But there's stuff that you need right now. Let's tell what this is not right. I'm scared now. Remember, we're worried about stroke and pulmonary embolus. So, severe headache could be a stroke and chest pain. We know there's going to be swelling. We know there could be sores that do not heal. That's normal. But the reported ones are the ones that could have a really bad outcome. The headache, stroke, chest pain, pulmonary embolus. What are the odds two sickle cell carriers would have a kid with sickle cell? It is 25%. Very good. Position for a lumbar puncture for young infants or a young child? And it is called lateral decubus. It's on their side, knees bent, and you sort of round the back so that those little bones in the lumbar spine separate so they can get the needle in there easily. I would always hold many times these infants and young kids. Number one, I'm soft and cuddly, but I would give them a big hug and I'd be talking about what a nice hug it was. And I'd be telling the kid, oh, you're going to have somebody's going to tickle you on your back and you're not going to feel anything, but okay, right now, right, don't move. You might feel a little, okay, you're good. And you know something? I talk them through it. And then the physicians, they don't have somebody tensing up and trying to move. And it's done very easily. Again, I distracted that child, didn't I? Distraction works just by talking sometimes. Hodgkin's or non-Hodgkin's? What is diffuse cancer of the lymph nodes? This is next, part we're going on, but this is an important one and I don't want you to forget it. And I'm going to ask it to you again. It is a cancer. I'm going to start the explanation. And that's exactly the way quizzes and exams always show up. Okay, let me tell you what I'm looking for. Hodgkin's or non-Hodgkin's has to do with lymph nodes, getting swollen and cancer in them. Hodgkin's is a lodge, a hodge, a house. You can see it, feel it, touch it. It's from the shoulders up. I can feel its big things and big lymph nodes sticking out, okay? Non-Hodgkin's is not a house. It's not a lodge. It's just like all over the place. So the answer is it's not a house. It's all over the place and it's non-Hodgkin's lymphoma. That's the way I want you to remember it. Hodge, lodge. And I've always remembered things by these little jingle lingles that I make up. I hope they help you. Wilms tumor. We've talked about that one already once, didn't we? So Wilms tumor is a tumor that is on one kidney. The big thing about Wilms tumor is that the membrane is very fragile. And if you touch it, manipulate it to assess it, it could, like little pieces, could micro colon and metastasize in the whole abdominal cavity. Wilms tumor. I've seen one in my lifetime, and it came to me from the hurricane in Haiti many years ago. And we found it while we were over there helping at our hospital. And we had a religious group pick them up at the airport, bring them right to the ER to my triage room. And I said, so what's wrong with this child? They says, we don't know. We were told to go pick him up and bring him here. I went, okay. Does he have any papers with him? They were all in French. So I had to do an assessment. So, number one, it was a 3-year-old boy. He is in a weird country, doesn't speak my language. I had to make it so I could do his vital signs, that I could touch his little belly. And the left lower quadrant, I felt about the size of my fist. I felt a mass. And for some reason, I knew what it was. So I immediately put a note on the chart, send him in, and it's what he had. End of story. He had the surgery and he went home and he wrote the unit to tell us, everybody, thank you. He had somebody translate it and send it to him. So, Wilms tumor. I'll never forget that one. Another child to tell you about. So, a child with Wilms tumor, what action by a nursing student causes a faculty member to intervene? What's not right here? What are they doing wrong? So, Wilms tumor, do not palpate abdomen. There should be a sign on the forehead, on the bed, over the bed, on the chart, everywhere. Do not touch. And it's a kidney tumor. Absolute contraindication for nasal tracheal suctioning include which of the following? When you're not going to suction the mouth? When? Remember, suctioning can increase the swelling, and it's that croup epiglottitis, tonsils. Yes, you leave the mouth alone. Create more problems doing that. Iron dextran is given via which route or route? Iron dextran is IM Z-track. Remember, we push it out, put the needle in, take it out, and we lock. I call it a lock and load. And then the medicine doesn't come out. Z-track. That was the first injection I gave as a student nurse to a young woman, and it was very scary. But she said I did a good job, so it was scary. What cancer may present with painless, firm, and enlarged cervical nodes? Up here, I've got my Hodges and my Lodges. This is a question that's, asked in many different ways, and it's always a 50-50 split. So I'm making sure you understand it. Painless, firm, enlarged cervical nodes. It's above the clavicles, Hodgkin's lymphoma. Very good. A multi. When teaching about sickle cell disease, you would include what? So we need to force fluids, right? We need to keep the blood vessels dilated. If it's warm, if it's cold outside, again, that causes constriction. Dress warmly. Go in an airplane, extra fluids. Take the pain medicines. And these children are usually given these Tylenol number 2 or number 3. It's a little bit of codeine. And they're told as soon as you hurt, take it. Because if you don't, by the time they get to the ER, I mean, morphine doesn't even help them. Dilaudid doesn't even help them. They really, really hurt. And as I said, any autoimmune immunosuppressed patient, ALL, sickle cell, cystic fibrosis, any of them, any fever greater than 100.5, they can't fight it. They have no immune system. They need antibiotics. Call the doctor. Thalassemia major is treated primarily with what? Mediterranean people. They also have these faces that are weird too. It's like they have big bones where their bones, little marrows inside these areas. So, what is thalassemia major treated with? Well, this is when the blood vessels die all the time. So, blood transfusions, inhalation therapy, and oxygen is needed. And last question. What is the most common opportunistic infection for children with HIV? And it is PCP pneumonia. Okay, pneumocystic pneumonia. Back in the 80s, I didn't even know HIV. It was very new. And I went to work at an adult trauma center as an agency nurse. And I walked into the medical ER and they gave me an area that I was going to take care of. And that night, I had an HIV patient who crashed with PCP pneumonia. And that's how I learned what PCP pneumonia was. I had a ventilator down in the emergency room with my other 8 patients. It was a heck of a night, and I will not forget it. And that's why I know what PCP pneumonia is. Let's go. KS, number 3, good job. Number 2, a KJ. We have the K's here. Number 1, Natalie. Good job, Natalie. Thank you. And we have a Susan and an. All right, let's go on with cancer. So, any questions? How are you doing so far? Hanging in there? So, children with cancer. I think this is probably the hardest thing to watch children go through. Watching them with cancer, watch them lose their hair, watch them suffer, be in pain. I also think that it can be one of the most rewarding um, positions for a nurse. Now, some of you who want to travel, you want to travel and make good money. If you stay in your area, become certified in children's chemotherapy, there are jobs where you can get like $25,000 sign-on bonuses to be there for a year. So it is an area. Now, it takes a special person. It is hard to see your patients die, but it's not that a child ever dies. What did you do for them while they were alive, for them and their family? Do you know I still have families of children who died who still reach out on every birthday and every nurse's week? This is Chris's favorite nurse. This is Olivia's favorite nurse. And these are things that you go with. Yes, you can cry. Yes, you can go to funerals. I've done it all. But it's you did good, and that's all that matters. That's all parents want from you, okay? All right. That's my lecture for today. So neoplastic disorders. Most commonly, it is blood or blood-forming organs when we talk about cancer in children, leukemias and lymphomas. So leukemia, what is leukemia? Well, it has to do with the bone marrow, lymphatic system, most common form of childhood cancers. It is more frequent in boys. And again, something you need to remember, poor Downs children. They're at high risk for leukemia, cardiac disease, and hypothyroidism. You'll see questions about that. All three things that you'll see these poor Downs kids, they have been given such a hard knock on life, and they smile and laugh and hug you all the way through. So, what is leukemia? It's what we call an unrestricted proliferation of immature white blood cells. That means your body's producing white blood cells, but they don't work. They don't. They're there, but they don't do anything. So no white blood cells. What's the problem? Well, no immune system here, right? So what are we going to see here? Well, we're going to get a history and we're going to get a physical. Now, I'm going to tell you another story, of course. I had a next door neighbor that was my neighbor for about 10 years, boy and a girl. We used to bring them to school together, his parents, my parents, they were around each other. The girl, unusual, she was about 13. She went to the ER, complaining of being fatigued and tired and flu-like, fever, bone pains, her knees were killing her, and she didn't know what to do. They did a CBC with a blood smear, and they found that she had a white blood cell count of 0.1. You usually be 7 to 10, 0.1. All right, that's how it's diagnosed. That's the history that you're going to see. What do we need to know once we figure this out? Well, we're going to have to do a lumbar puncture. We want to make sure it's not in the whole central nervous system, okay? And again, have I said it 29 times yet? Be honest about the procedure, the bone marrow. You may experience pain, but we'll do everything to make it as little as possible. So, therapeutic management of leukemia. Once we have done that smear and we've seen it, once we've done that lumbar puncture, looked at the central nervous system, we're going to insert a central line, a PICC line or a port, usually a port with leukemia, because we want something that's more to stay there for a year or whatever it's needed. And it could be on the right, left, or middle of the chest, but it's under the skin, so it doesn't hang out all the time. So it's a great thing for these children. The first 4 to 6 weeks of that therapy for leukemia, you know what our goal is? Remission. And you're thinking, I'm going to be remiss after 4 to 6 weeks? Yes. What they do is they hit these kids and adults with really, really hard chemotherapy. And it destroys all the cancer cells. Yeah, it destroys some of the normal cells too. The goal is they're going to be in remission, but they keep going. Central nervous system, they'll put some chemotherapy in to make sure the cells aren't hiding anywhere. Then they'll do the consolidation therapy. There might be some hidden cells that didn't come out and they're still looking for them, right? We can get them. And then they'll put them on a maintenance. So, goal of induction therapy, remission. Now, there are times where you're doing all this chemo and it's just not working. So there is a thing that we can do is we can do a stem cell transplant, bone marrow. We can give it somewhere. Now, there are two types of bone marrow. If I was a baby and my mommy saved my umbilical cord, that is my blood, okay? That is automatically me, mine. It's the best for me, autologous. Automatically, it's the best for me, okay? Now, don't have to be A positive, O positive, no. They say siblings is the next, of the same mother and father, is the next best thing, but it can be from anybody. And that's all the others, allogenic. So 2 types of stem cell transplantation. Automatically, mine's the best. autologous, and all the others allogenic. Now, how are we going to treat leukemia? I mean, this is like a long-term thing. They're going to be on really incredible chemotherapy. We're going to be knocking out their whole immune system because we have to kill all these cancer cells in there. So again, prepare them for procedures and being honest again, right? Alleviate that pain because they hurt. Like, she was a little Korean girl and her name was Young, and she had really, really bad knee pains all the time. And that's what she complained of. And I had to tell her, hey, if you hurt, tell the nurse. They'll give you something to help you. The complications that occur with no white blood cells is infection. Now, it also hits the red blood cells because, not only attacks white blood cells, it's red blood cells and platelets. So it's going to be like an aplastic anemia looking thing here, right? We're going to be apt for white blood cells. We're going to be immunosuppressed. Red blood cells, we're going to be anemic. It's going to be low. Platelets are going to be low. We're going to be bleeding. All of these things are part of leukemia. The prognosis has to do with what was that white blood cell count when we first came in. I mean, Young was 0.1. I've actually seen 0.01, and that was the lowest I've seen. It's like they didn't have any, white blood cells at all in them. How old were they? Young kids do really well. I mean, Young was like 13. That's unusual. I mean, today she's a PhD psychologist from the University of Miami. I mean, she's doing well, but it was a hard time there. And she was an ALL. AML is harder to cure than ALL, for you to know. Okay. And girls do better than boys. And then what is your blood type? Are you a very unusual blood type, so you can't get blood when you need it? Or are you an A positive? Everybody's got A positive, right? So in cancer, how do we treat it? Well, leukemia, we do chemotherapy, right? But there's other stuff that we have. So we can do radiation therapy. Now, radiation therapy depends on the age of the child. Not all children are old enough or big enough to get it. That's the radiation. Chemotherapy is done, and this is to shrink tumors. So by the time they do surgery, they're not removing big pieces of the brain or the liver or the whatever. So early detection. So here we are. This is little Ming Young, what she looked like. She had pain in her knee. She had a fever. She had bruising, petechiae. She was lethargic. She was malaise, anemic, and she did have lymph nodes there. I mean, vision change is not really, but these are the types of symptoms you see with leukemia. Now, as we start to give chemo, we're knocking out the entire immune system. So we know our neutrophil count will go low. Now, it's not just children with leukemia on chemotherapy that can have low neutrophil counts. Well, what is a neutrophil? It's a white blood cell. So if your white blood cells are low, what's the problem? We're worried about infection. So let me give you a scenario. You're a nurse on duty. You get 4 patients. One of those patients has a fever and a neutrophil count of 500. That's your priority patient to see, because neutrophil count of 500 means there's no immune system. This kid, and they have a fever already, they are about to crash and burn on you. This is your priority patient. This is why I mentioned neutrophils. Less than 500 is severe. It should be almost 2,000 is what the normal thing should be. How do we treat neutrophils? Well, we're going to be doing blood cultures, urine cultures, sputum cultures, and we're going to be starting broad spectrum antibiotics. Give that body something to fight what's going on there. And because we know that infection is the big what's going on with that neutrophil count of 500. In chemo, there's going to be hemorrhages because platelets are low. So activities, making sure that they're not out on bikes and skateboards and doing crazy things that they can bleed from, right? And we know anemic with hemorrhage, they're going to be tired. So give them rest breaks in between. Nausea and vomiting is a big thing. I'll tell you a story about when I became a nurse. You couldn't give an antiemetic until they vomited. So I used to give it and say they vomited already because they're nauseous. They're about to, vomit. Then they realize, oh, we should be proactive. Why shouldn't we make that patient vomit? If they're nauseous, give it. So I'm telling you, so many changes in the practice and the way we deliver things. I mean, we're using cannabinoids a lot. We use them with children. I've watched so many documentaries on it. I mean, it's controversial, yes, but as long as it's in combination with medical care, does it hurt? I don't know. And then altered nutrition. These kids are going to have usually sores in their mouth and whatnot, and they're not going to be feeling good and they're tired, etc. So, what foods do we need to give? We need each bite to be the best bite it can be. High protein, high calorie, high fat. See that? One bite's giving you a bunch of good stuff. They can also get hemorrhagic cystitis because, again, platelets are low, they can bleed, so you'll be watching for it. And then I think the one thing that all people worry about is that alopecia or loss of hair. I mean, I've seen fathers, brothers, uncles, grandpas all shave their head for their kids. I used to go and get these little spools of ribbon, all different colors, and I would make headbands and bows and things, and I'd wear the same thing with the kid. So I'm like, oh, but you got hair. You don't have hair. I do. I think you're cuter than me. So you make it not a bad thing. The other thing that happens is a lot of times they're on steroids and they get that big moon face. Again, older kids feel big and puffy. Make sure their clothes are not these tight things that make them feel more self conscious. That's what that means. Again, preparation for procedures. Now, bone marrows are usually, they've done their sedation, but again, do it on their level, be there for the child and the parents, and know that, make sure that physician uses that numbing stuff on the outside and deep infiltration to make sure that's not going to hurt. And again, be honest with that child. Pain management, again, opioids are used very, very well. Again, using the FLAC or the FACES scale. Remember, FLAC up to 3 years old. At 3, it's FACES, and FACES can be used forever and ever and ever. You don't have to go to numeric if you don't want to. And remember, FLAC is also nonverbal children. Health promotion, we know with kids, if they're sick, they still got to go on and get what they need, but know that immunizations, live viruses, contraindicated because it can give them the disease. Inactive vaccines, we'll use those. And family can receive some live, but you got to check it out. And this one here, varicella, is extremely dangerous to these children. They need to get the varicella immune globulin, okay? That was a Hesse question. Here we are, Hodgkin's lymphoma, non-Hodgkin's. Do you see the Hodge there? Do you see that big thing that's sticking out? Feel it, touch it. It's easy. Hodgkin's above the shoulders. So metastasis can also in the lymph nodes. It's usually above the clavicles, and it can metastasize like any cancer anywhere. I've given you pictures of all different things to show you it. You can feel it and touch it. It's what we call painless, enlarged, firm cervical or supra above the clavicle lymphadenopathy. So that is there. Now, what happens? Think about it. Lymph nodes are getting big and swollen and pushing and squeezing the airway. What happens if they start coughing? It gets harder to swallow, okay? Abdominal discomfort. They don't want to eat because they just don't feel good here. So fever, anorexia, weight loss, and night sweats is part of it. What we do is a lymph node biopsy. They'll take and you numb it up, usually anesthesia, and they'll take a little piece of it, and we look for Sternberg-Reed cells, and that gives the positive diagnosis of Hodgkin's. Now, with Hodgkin's, if you have one of those big, big lymph nodes, you can't just take that whole lymph node out. It's half the neck. So we need to shrink it. Again, Radiation depends on the age of the child. Not all children can be given radiation, okay? Most of them, they'll get the chemotherapy, let's shrink those lymph nodes, and then they'll do surgeries. These children, because of radiation and chemo and whatnot, they will be high risk for infertility. It's one of the things because of the amount that we have to do to them with radiation, etc. Now, non-Hodgkin lymphoma, you don't really see it in the neck, do you? You see it more everywhere else, like underneath the arms and in the abdominal wall, sort of thing, okay? It's diffuse. You can't feel it. You still will go and do the biopsy and confirm it, etc. And then they'll be doing all sorts of chemotherapy. Again, it almost looks like a chemo of leukemia here. And we'll be given that induction, consolidation, maintenance, right? Induction with our goal is remission, and that's what we'll do for them. Now, brain tumors. Most common solid tumor. What do you see? What is a kid going to be complaining about? Well, they might be young and hydrocephalus, you might see, but usually they're a little bit older, complaining of headache and vomiting. And then you might see those eyes wiggling, that nystagmus thing going on, and then ataxic. Their movements is getting a little weird. Now, remember that when we're talking about children with a brain tumor, diabetes insipidus could be showing. Why? Pituitary gland can get squished or be a pituitary tumor, and that could show the signs of diabetes insipidus. And again, growth failure. You're not getting what you need. So how do we diagnose a brain tumor? Well, the symptoms, number one. Then we're going to go, regular X-ray, CT, MRI, LP, all of those, and do a biopsy. Now, if we can do surgery, I mean, they literally shave the head and split it open like those pictures here, okay? They'll do the radiotherapy, the chemotherapy, and then do surgery. We want it shrunk as much as they can. Post-operatively, as nurses, we've got to be very careful, okay? Positioning. Sometimes, can you position them on that side that was surgery or not? Can you elevate the head of their bed or not? There's brain drains that look like Jackson Pratt's. Can we touch them? Do we empty them? All of these things we need to know. Another big thing is fluid management. We have taken and we're working on the brain. Fluid overload can cause swelling and cause problems, okay? And then, of course, always pain control. Now, another type of cancer is a neuroblastoma. This is a weird thing. Usually it starts in the belly, the abdomen, and then it already has metastasized to the brain by the time we know it. It's all you need to know about it, and it's something that's not that common. That's all I want you to know about that. Now, bone tumors. One of the ones that, that I talk about is an osteosarcoma. Usually what we see it is the femur bone gets a cancer on it. And what we'll see is different things. But the bone gets more and more, and the tumor gets a little bit larger. And all of a sudden, especially in the morning, especially after they've been sitting, they'll be limping, right? And they're going to be more pain. And then they're going to start to be able to feel it. And then the fever starts. Now, we can cure bone tumors, but we've got to figure out what it is and how do we have to do it. So let's do our history physical. Let's do all the exams that we need to do, all the x-rays. And of course, let's do blood tests. If it's a cancer, worried about CBC, white cells, etc. So osteosarcoma of the femur bone. Now, you can't just take the cancer off. It's not like taking a piece of the liver out in a tumor. Don't work that way. The whole femur bone must be removed. Can you imagine? And this is usually adolescents. What they do is they take the lower leg, turn it around, put it up into the hip joint, and attach it. And why? is a place to put a prosthesis. Okay? Our goal for osteosarcoma is that we can salvage the lower limb and use it. That is the goal. Wilms tumor, we've already talked about it. But again, we've already had questions on it. It is painless. It's a swelling in the abdomen, and they usually don't find it till it's big. Like what we found that little boy from Haiti. So we did the history and physical. I did that, figured it out. And then they did a quick ultrasound CAT scan. And then the kid was done chemo and he went to surgery and got rid of it. Remember, no palpating this preoperatively. Okay. Big, big thing. Postoperatively, where are the kidneys? They're on their back. So they're at the bottom of the abdominal cavity if you're laying on your back, right? If you're laying prone, it's at the bottom. So they have to go through all of these intestines to get back there. So postoperatively, we've touched the kidney, so you're going to worry about urine, but you've also gone through all of these intestines. Now you're worried about it going into a megacolon, right? Worried about bowel function. Retinoblastoma is a tumor in the retina. And I've seen one, and it was a young baby, 8 or 10 months old, and one eye just looks white. It looks like the old when you took camera with a flash, and all of a sudden the eyes would go white. That's what it looks like. And that's what it is. When you get a child with a retinoblastoma, one of the things we need to know is any assessment on that eye. Have they been having troubles? Has it been red? Has it been infected? Is the kid touching it? Has it been injured? I mean, all these things, we need a report about that eye and anything that's happened. They do radiation therapy on it. And you see that little purple mark there? That's a radiation mark. And you cannot take it off until radiation is done so that we can direct the radiation in the same exact spot every time we do it. Okay. We used to have what we call washing the marks off, parties, for these kids also. So we do the radiation, we do the chemo, we take the whole eyeball out because the eyeball retina is inside of it. And then what we'll do is they'll put in a prosthesis, whatever type, little round ball or one of these, whatever it is, so that the kid looks normal. Germ cell tumors. These are testicular cancers. Women do breast exams every month. Men should be doing testicular exams. Now, I had an 18-year-old boy come into the triage room, and it was with the other nurse, but I was doing one patient listening, and then we talked. 18-year-old boy come in with testicular pain. Of course, we've got to do the vital signs, take the history, and then we need to inspect what the pain is. So we put on gloves, and the nurse checked it. One of the testicles was the size of a softball. So we sent them back to the ER, and they did an X-ray, just a body X-ray, and this kid had metastasized all over his body, and he actually died about 3 months later. So testicular cancer is a big thing, and it's basically checking themselves every month. Liver tumors, our livers grow back. So we can take out a lobe and it can work again. Yes, they're sick post-transplant, but they do really good. So childhood cancer. When I first started in nursing, cancer, got many people and it wasn't really curable. But with all of the things that have been going on, the treatments and the medicines, et cetera, we're doing so much better. So people are living better all along. And I love these things that I see on Facebook where cancer free, after treatments or all that good stuff. All right. Who wants to see the next cahoots? Any questions? Okay, let's just get going. Answer. 19 of them. A child is admitted with neutropenia. Which nursing action takes priority? You know this one now, right? And it's hand washing. Remember, neutropenia is a low white blood cell count, which no neutrophils, right? That is white blood cells, and we have to be worried about giving this child, adult, an infection. Which symptoms would a healthcare professional expect to see in a child with leukemia? So remember, leukemia affects white cells, red cells, and platelets, right? All of them. So bruising, fatigue, and bone pain is part of it. And anemia would be there too. Child with a Wilms tumor. What action by the nursing student causes the faculty member to intervene? So palpating the abdomen in all four quadrants is nothing what we do for Wilms tumor. Remember, do not palpate abdomen because that little jostling could cause metastasis and we don't want to do that. Thank you. Your child has ALL, has recent lab results, and the platelet count is 10,000. What do you do? What's your part of your care plan here? You have cancer, you have leukemia, ALL. My platelets are 10,000. What does that mean to you? Platelets are all about bleeding. So you put them on bleeding precautions, just like ITP, right? We're not going to do any venipunctures. We're going to be checking them for bleeding and we're going to be checking labs. This is what we're going to be doing. A child with ALL has a fever of 100.5. What should they do? So a child has a fever of 100.5. Remember, ALL, they're immunosuppressed. They have no immune system. They need to get to the doctor now. And what are they going to do? They're going to start an antibiotic, depending on the child, send them to the ER or start oral. It all depends. A child is having a bone marrow aspiration. What should you tell the child? Look at the size of the needle that's stuck in there. And it looks, sometimes they'll take that little blue thing, screw it in, and then put a syringe and suck out, the bone marrow aspirate. Again, thank you so much. It's going to hurt a little bit, but we're going to do everything we can to make it as little as possible. Good. The most common clinical manifestation of a retinoblastoma. So it's called a cat's eye reflex, and we call it that for this reason. If you have an animal out in the dark and there's a light in the background, those eyes will shine. It's like cats or dogs. I mean, bears. I mean, they all do. But you're going to see that whites, and that's the cat's eye reflex. That's what they refer to. Your child's been diagnosed with a retinoblastoma. What information is important? So our big thing is we just want to know, has there been anything going on with those eyes? Was there something that led up to it so that we can figure out exactly what's going on? A goal of surgery for a child with an osteosarcoma is. So we have a child with osteosarcoma. We talk about osteosarcoma being that femur bone. So our goal, because we've got to get rid of the whole bone. You can't take a piece, you just can't take a tumor. The whole bone has to be taken out. We want to be able to salvage that piece of limb to put it back up there so there's something to attach a prosthesis to. A child is complaining about skin markings for radiation therapy should be told what? Again, those skin markings are there. They have to keep there so that we give accurate, same zapping of that radiation to the same place. Again, we have these radiation mark, washing them off parties. And the kids love that. What assessment question needs to be asked to a child with possible rheumatic fever? So again, rheumatic fever has to do with a strep infection. Remember, everything can be, turned back to normal, except if that mitral valve's been damaged, that's not going to come back. It's going to be treated medically or surgically. It's damaged, it's damaged. If a child was to receive their own bone marrow, it is called a blank transfusion. Automatically, mine is the best. Autologous. Good. What cancer may present with painless, firm, and enlarged cervical nodes? So again, when we're talking about cervical, painless, firm, enlarged cervical nodes, this is a lymphoma. This is Hodgkin's lymphoma. It's a Hodge, a lodge, a house. I can feel it, okay? Non-Hodgkin's, I can't feel it. It's all the other places. A multi. Treatment of osteosarcoma includes. So stem cell transplant has nothing to do with this cancer, osteosarcoma. If you have a bone cancer, that it just has to be removed, period. So we'll do chemo, radiation, shrink it, and our goal is absolutely to salvage the limb, but there's times we can't. So that would be the amputation. A multi. Who are the best donors for bone marrow transplantation? So automatically, mine is the best. But if I have to have somebody else, I might as well have my siblings. Again, from the same parents. Those are good. Can mom and grandma? Yeah, but this is best. Best is yourself or siblings. Then it goes down, mom, grandma. What would you consider to be neutropenia or a low neutrophil count in children? So we say neutropenia is less than 500. You're going to see neutropenia is described as what happens when we give chemotherapy, with our goal of the induction is, remission. You do kill off some of those white blood cells, in these children. So it's less than 500. But there's also that child who's severely septic and their neutrophil counts are very low for whatever their condition is. It doesn't have to be leukemia. It could be they're just overwhelming sepsis, they're not doing well. That's a child also with a fever, low neutrophil count. That's your priority patient always. A primary characteristic of a brain tumor is so a brain tumor, its symptoms get worse over time, which is I'm going to start not being unbalanced. I'm going to be vomiting, but it's not related to eating or anything. I just vomit, at all different times. Not occasional headaches, headaches that are getting worse over time, headaches that will wake them up at night. That is the brain tumor. Those are the symptoms that you do see. The optimum treatment for an osteosarcoma is, what is our goal? So, osteosarcoma, our goal is to be able to salvage that limb so that we have something that that child's able to put a prosthesis on and to be mobile. As simple as that. I mean, again, that's our goal, but sometimes it ends up amputation. We don't want that. And last question. A child's receiving the induction of chemotherapy. What does that mean? So, induction, the initial intensive chemo, and the goal is remission. Yes, there's three other steps, but that's to catch little things, little cells that they missed to make sure that that cancer is gone. Let's see how we did now. Number 3 is Susan. Good job, Susan. Number 2 is ST. Oh, we got the S's now. And number 1, Natalie. Good job, Natalie. Number 4, a KJ and an NT. All right. So as I said, this is always, my shorter class. I don't know why it always happens, but it's the one that usually we're a couple minutes early. Remember, this week you do have your NCLEX questions. Make sure that you do what they're telling you, which section's on it. Also, if you've not sent me your topic, please send it to me, so that I can confirm that for you. As again, try to pick something that's interesting to you. There is a list in Module 8. If you can't think of anything, you can choose one of those. There's like 30 some on there if you want, but it doesn't mean that that's all that you can choose. Something that has to be with a kid, it's something you could use, okay? Remember, I'm not going to be here next week. You're going to be with Professor Luminoso. I already have an announcement set up with her Zoom link there. It doesn't mean I'm not reachable, okay? If you need me, reach out. It just might take a little bit of time for me to get to you, but I'm usually pretty good, okay? Any questions?
I have a question. If we plan on doing the exam at campus, do we still
I
need
need to know.
okay,
Yes.
so
Yes.
email